Good morning, good afternoon, and good evening, everyone, and welcome to our webinar titled Data Collection and Analysis in Human Autonomic Research, How to Guide Successful Testing. This is Liam Sanyo, and I'm very pleased to be your host for today's event. This program was developed through a collaboration between the American Physiological Society and ADInstruments in support of their shared mission to provide education and value to researchers everywhere. We're really excited to have Dr. Jacqueline Limberg, Assistant Professor in the Department of Nutrition and Exercise Physiology at the University of Missouri, here with us today. And she will talk about the basics of human autonomic research and share some tips and tricks for data collection and analysis during human autonomic testing to improve the accuracy and reliability of your findings.
Nice, thank you, Liam, and thank you to ADInstruments and the American Physiological Society for inviting me to give this presentation today. As Liam pointed out, I am just started my 4th year as an assistant professor at the University of Missouri. And so the outline of the presentation today is really to get those of you who are also going to be starting up a position or who are interested in transitioning to doing some human autonomic testing in your laboratory, just some suggestions. And so first, I'm going to talk about selecting some equipment that would be appropriate for answering questions related to human autonomic testing, as well as creating a research center setting that's conducive to reliable data. So a human autonomic lab may look different than some of the laboratories and your colleagues in labs around you. With that, I'm also going to try to help you identify some of the tests that might be appropriate for your research questions, whether they relate to basal or reflex autonomic control, and the pros and cons of some of these tests, with the ultimate goal of just helping everyone try to anticipate and avoid areas that could increase data variability or reduce your ability to interpret results as you start collecting your data. So thankfully, this is going to be recorded because I will be using some acronyms today. So if any of these don't look familiar as you go through the presentation, please just refer back to the recording and hopefully this will help you. I'll also try to define all of these as I move through the talk. So just to get everybody familiar with what we're going to be focusing on today, we're going to be looking at the autonomic nervous system and specifically how we can measure autonomic nervous system activity in human research participants. So the autonomic nervous system is a branch of the peripheral nervous system, which you can see up here on the top. And the role of it is really to communicate between the central nervous system and the rest of the body. So one thing that I really like about the autonomic nervous system is that it controls involuntary responses. So a lot of the things that are going to happen in the laboratory with your research participants, they're not even thinking about doing. These are all going to be reflexes, which is really cool. The downside is that you need to control for a lot of other things in the lab space or outside of the laboratory that could also affect these involuntary responses. And with that, we're also going to be focusing on the 2 branches, specifically the sympathetic division and the parasympathetic division of the autonomic nervous system as I go through the presentation. So really, what is the autonomic nervous system? It's an important tool, like I mentioned in the previous slide, that the central nervous system can use to maintain homeostasis. So because of this, you could just be studying your participants at rest, or you could also examine the response to changes in physiological state or stress. And this homeostasis that I'm talking about is achieved through changes in activity of both the parasympathetic and the sympathetic nervous system branches, like I mentioned in the previous slide. So when I think about looking at the autonomic nervous system in human research participants, there's 3 things that I really focus on. First is just what is the activity of the system. So sometimes I may call this baseline activity or basal activity, but this is really your participant in the resting state. This is the natural or normal function of the system. And according to Merriam-Webster Medical Dictionary, so processes that the organism carries out just by virtue of being alive. But because the autonomic nervous system also plays a role in responding to stress, we can look at the sensitivity of the system or the capacity of the organism to respond to stimulation or the reactivity of the system. So the state of being reactive or responding to a stimulus, for example, in the result of stress. And so I'll be talking about each of these different areas as we go through the presentation. But the neat thing is that whether you're looking at activity, sensitivity, or reactivity, all of these are very clinically relevant. So here we're just going to look at activity. So this is a measure of muscle sympathetic nerve activity, which you can see up here, MSNA. So a measure of that activity, the branch of the sympathetic division of the autonomic nervous system. And what they did here on day 0 is they just measured activity of the sympathetic branch of the autonomic nervous system, again, muscle sympathetic nerve activity, and they divided individuals into those that had high activity, so what we're saying are greater than 49 bursts per minute, or low activity, or less than 49 bursts per minute. And these are patients with heart failure. But what you can see is as they follow these participants out, you can see that activity of the sympathetic branch of the autonomic nervous system can predict mortality in these patients. If we move to sensitivity, and here we're looking very specifically at cardiovagal baroreflex sensitivity, but you can see the figure actually looks very similar to the activity graph. And these are, again, patients with heart failure. And you can see those individuals with low baroreflex sensitivity in the continuous lines have a greater, is predictive of mortality as well when you compare it to those individuals that have low baroreflex sensitivity. And although I don't have a figure for reactivity, the story is quite the same. And this is from a review from Jason Carter and David Goldstein in Comprehensive Physiology just in 2015. And what they see here is that the variability in the autonomic responses to stress, so what I'm calling reactivity, could provide a unique window of insight into hypertension and other cardiovascular diseases. So with that, if you haven't noticed yet, I'm a cardiovascular physiologist. So when I'm thinking about autonomic nervous system activity, sensitivity, or reactivity, I'm going to be focused primarily on how the autonomic nervous system modulates cardiovascular function. So with that, I just want to walk through this schematic for a second. So if the autonomic nervous system plays an important role in homeostasis, one of the most controlled variables when you think about the cardiovascular system is going to be blood pressure. So we think about how the autonomic nervous system modulates blood pressure. Let's say the blood pressure goes up or down. This is going to be sensed by the arterial baroreceptors. So I talked about baroreflex sensitivity in the previous slide. So we're going to sense a change in blood pressure or a change in homeostasis. This information is going to be then sent to the central nervous system, where you're going to have processing of that information that will elicit a reflex response. And this is often what we're going to be measuring in our human research participants. And again, we could be looking at the sympathetic branch of the autonomic nervous system or the parasympathetic. And in this figure, when we think of parasympathetic nervous system activity or modulation, we're primarily looking at the cardiac vagus, or the vagal nerve feeding the heart. And then when we have these changes in sympathetic or parasympathetic nervous system activity, you are going to get then changes in heart rate, stroke volume, or resistance vessel tone. Those things will then feed back to modulate cardiac output and total peripheral resistance to get your blood pressure back to where it should be. So this is really the idea of the autonomic nervous system maintaining homeostasis. And the really cool thing is we can measure all of these in our human research participants, and I'll be walking through that throughout the rest of the presentation. So first, you just get your faculty position, you're going to get your research lab started, and the chair of the search committee says, what do you need for your research setting? And if you're going to do human autonomic research, your research lab may look different than the lab of those colleagues next door to you. And so we need to focus just for a little while on what you need to do to have a research setting that's conducive to reliable and accurate data. So this table here on the right actually comes from a review article that we recently wrote in AJP Heart as part of guidelines paper. And so I encourage you to refer back to that paper or a similar paper by Emma Hart and colleagues that was also published as a guidelines paper in 2017. But the first thing you need to think about when you have a lab is that it should be temperature controlled. You don't want the room being too hot or too cold because that could alter autonomic function, right? This is all involuntary, is what we're thinking about. Your lab also needs to be quiet. And when I think quiet, I think void of distractions. So during testing periods, individuals shouldn't be having conversations, there shouldn't be loud music, people shouldn't be coming in and out of the laboratory. Things I think about are people opening drawers, looking for a pen, dropping a notebook, or my lab actually backs up to a laundry room, so somebody deciding to, for example, throw in a load of laundry. And the reason this is really important, and I could have picked a lot of different figures, but this is from Murray Esler and Gunnar Wallin. And what you can see on top is the lab is measuring muscle sympathetic nerve activity, so activity of the sympathetic branch of the autonomic nervous system. In the middle, we have our controlled variable, which is our blood pressure. And on the bottom is R intervals. So think about heart rate. And if you remember from the original figure, we're thinking about parasympathetic and sympathetic modulation of heart rate. So what you can see is that during this testing period, at the beginning, these variables are relatively stable, but then there's a noise in the lab and the participant's startled. And you can see these drastic swings in sympathetic activity, blood pressure, and heart rate. So think about if you were trying to figure out basal autonomic function in your research participants compared to another group of participants. But in some of them, during the testing period, people were opening drawers or vacuuming in the room next door. And all these things are going to alter these involuntary measurements that we're having in our participants. So it's incredibly important that you're testing basal control and not your participant's response to what happens when a vacuum cleaner gets turned on. So not only should your room be quiet, but your participants should also remain quiet. And so these are data that we collect in the lab using LabChart. And so you're going to see this throughout the presentation. But what we've got up here in the red is our ECG for heart rate. We've got beat to beat blood pressure here in the blue. And then I have the participants wear a respiratory belt just so that we can monitor breathing rate. And here we also monitor inspired and expired oxygen and carbon dioxide, and then tidal volumes or just the size of their breaths. So this is what we would expect in a normal quiet resting period where I want to look at basal autonomic function. Now this is a participant that during the testing period asked a question or started having a conversation. And so what you can see is these huge fluctuations in the respiratory belt. We see changes in oxygen, carbon dioxide, tidal volume. You see this sputtering in the blood pressure channel. So the point being, when we start our measurement periods, we always make sure the lab room is quiet, the researchers are quiet, but that we also ask that our participant engage in a quiet resting period as well. If a participant were to start talking during that testing period, you really should repeat that testing period because as you can see, you're no longer looking at basal autonomic control. You're looking at changes in heart rate in response to somebody talking. And then if anything, I hope this encourages some of you to maybe use a respiratory belt during your testing because otherwise when you go back through the data, you might not know why you're having these sputtering in blood pressure. And by having a respiratory belt, you can kind of get an idea whether your participant's talking or not. So these are things inside the lab, but what about outside the lab? So in general, we ask all of our participants to refrain from alcohol, caffeine, intense exercise, and smoking or nicotine for at least 12 hours before an experiment. And to be honest, in most of ours, we actually do it for 24 hours, as well as food and drink then for at least 3 hours before the experiment. Because again, we want to make sure that we're testing individuals during their resting state and not a response to, for example, a meal. And if you're studying individuals that are insulin resistant, that 3 hours probably needs to be extended a little bit longer. One of the reasons that I suggest that maybe 12 hours is a little bit too short is there was actually a really interesting paper that just came out looking at binge drinking. So the effect of drinking the night before testing. And just think about if your individual had a couple of beers with dinner and then you tested him the next day, you might not actually be looking at their basal function anymore. The other thing is that there's a lot of diurnal variation in the autonomic nervous system, so you're really going to want to have your experiment scheduled at the same time of day, ideally after a normal night's sleep. There's a lot of great work from Jason Carter's group looking at the effect of sleep deprivation or sleep restriction on sympathetic activity. And all your testing should be done during wakefulness. It's really hard to do testing in a quiet room, dimly lit, quiet room with no excitement, and then ask your participant to stay awake the entire time. But there's some really nice work from Viren Summers that has shown that when the participant falls asleep, you're going to have changes in autonomic activities. Your participants really need to stay awake. Last but not least, all your participants should be asked to void their bladder before testing. And I have a really nice example of that in the next slide. So this was a study we actually did just a few weeks ago. And so it takes a while to get instrumented for these types of studies. So if you can see here on the left, we started our testing or baseline measures around minute 48 after instrumentation. And so what we've got on top is our heart rate. Then we've got our beat-to-beat blood pressure in the blue, our respiratory belt here in the green. And then we did direct recordings of sympathetic activity, which I mentioned earlier, or muscle sympathetic nerve activity. And then for fun, I threw on here, we also used the NICO software extension in LabChart to get measures or estimates of total peripheral resistance. So we did our baseline measures here, and then about 20 minutes later, we were ready to start our intervention. And if you can see, we identified, gosh, his total peripheral resistance is up a little bit. Look at the nerve, it looks like we're having an increase in muscle sympathetic nerve activity. We haven't done anything yet. So we're about to get ready for the intervention, and 5 minutes later, the nerve is even louder. And so we're thinking, what is going on? Maybe the participant's in pain. This will happen sometimes, if they have an IV and it's pinching or tugging, or their neck's at, their back's at an unusual angle and they're having back pain. So we're trying to figure out what it is before we start our testing. And then at minute 84, so 10 minutes after that, the participant says, I need to use the restroom. So this is just a really good example. If you aren't doing direct recordings of sympathetic activity, but your participant tells you, I need to use the restroom, take into account that maybe for the last 30 minutes, your data have been compromised, because that has a significant effect on sympathetic activity. Last but not least, it's standard practice to inquire about past and current medical history and current medications. We do this all the time to determine whether our research participants meet our eligibility criteria. So there's controversy whether certain medications, participants taking certain medications should be excluded, whether the medication should be withheld, or whether the medication should just be documented. And the point I want to make here is that regardless of what you decide, documentation is key. So that includes documenting whether your participants are taking vitamins, oral contraceptives, hormone replacement therapy. And with that, it's also really important to document menstrual cycle. And there's a great counterpoint that was just published in Journal of Applied Physiology, with also a series of letters to the editor. So I highly recommend you take a look at that when you're trying to decide what you want to do with participations as far as controlling for menstrual cycle, oral contraceptive use as well. But the key here is documentation. You should be know who you're studying. All right, so now that you've got your lab space nice and quiet and your participants haven't eaten recently or taken any sort of medications or alcohol, it's time to start your study. So you need to decide what equipment you need, and knowing what equipment you need will be dependent on what your research question is. So for example, are you interested in measuring basal or reflex autonomic control? I'm going to try to help you understand some of the pros and cons of these tests. So I'm going to focus first on activity. So if you haven't recognized yet, we're going to go through activity, then we're going to go to sensitivity, and then I'm going to finish up today with reactivity. So if we're just looking at the natural or normal function of your participants, you're going to need a really nice, quiet research laboratory. And then you've got some options as far as the arms of the autonomic nervous system you want to study. So we've got the cardiac vagal activity, which we're saying is the parasympathetic branch of the autonomic nervous system, as well as your sympathoadrenal activity. And I'm just going to start here with cardiac vagal activity. Now you're going to notice, for those of you that do this testing regularly, I don't really have a lot of tests or procedures suggested here. I tried to keep this presentation relatively non-invasive. However, there are a lot of different pharmacological approaches that you could also use to modulate activity of each of these branches of the autonomic nervous system to look at function. That being said, I do just want to highlight some new areas of research in the field. So if you're interested in cardiac vagal activity, prior to 2020, there were no papers really looking at direct neural recordings. And so I just want to refer you to this recent paper in JPhysiol by Von Masefield. There's also a really nice video that I have the link here. So if you're interested in looking at cardiac vagal activity, this is a really nice paper to take a look at. But that being said, most of us aren't going to be doing direct neural recordings from the cardiac vagus. And so what I'm going to focus on primarily is measures of heart rate variability. So the premise of heart rate variability is that you're looking at this beat-to-beat variation in the length of the cardiac cycles. And so we can interpret this in that the greater the heart rate variability, or the greater beat-to-beat variation in the length of the cardiac cycles, the greater the modulatory influence of the cardiac vagus, which we're again using as a measure of parasympathetic. And so what I'm talking about when I'm saying beat-to-beat variation, if you look down in this figure, these are the milliseconds of the R-to-R intervals, or the variation between the heartbeats. And you can see one's 828 milliseconds, the other one's 845 milliseconds. And so you can see there's some variability beat to beat in that R-to-R interval. And this is a really valuable non-invasive measure of this non-stationary balance between the sympathetic and the parasympathetic branches of the autonomic nervous system. And so you can again see non-stationary, right? These milliseconds, 845, 754, they differ beat by beat. So this slide is purposely very full of words. And that's because what I'm going to show you after this is that ADInstruments in LabChart now have a really nice push-button approach to heart rate variability. That means if you collect B2B ECG in your research participants, you can essentially go in, push a button, and get measures of heart rate variability. And I just wanted to detract from that a little bit because I think you really need to know what you're measuring and recording from before you can really interpret your data. So some things you need to think about before you just push the button and get the results is that heart rate variability is going to be dependent on your sample rate. So you need to be sampling your signals, your ECG signals, at a high enough rate that you have a 1 to 2 millisecond resolution. Because as you noted in the previous slide, there's a very small millisecond differences between R to R interval. And if your sampling rate is too low, you won't be able to detect this, especially if your sampling rate is under 200 hertz. So I recommend a sampling rate between 500 and 1,000 hertz, and we typically use 1,000. Then you need to know your filter. So I use the BioAmp from ADInstruments, and so I'm able to do a digital filter. But if you're not using the BioAmp and you're using an external device, you need to know what the filtering is on that device before you can be confident in your heart rate variability data. So you need to be able to check the frequency of the response of the filter and just verify that the spectral components are not altered by the filter from whatever piece of equipment you're using to collect ECG. The other thing then is that you need to standardize your recording lengths. So if you're going to measure heart rate variability, you really need a file length of about 5 minutes or 250 cardiac cycles. And then you need that file length to be consistent between participants or interventions. You also need these physically stable conditions. And I think I hammered that point pretty hard in the earlier portion of this presentation. Your participants can't be talking, you can't be startling them during the testing, or you really need to start over again. The other thing you need to do is do some visual checks and manual corrections of your data. Because if you have any sort of ectopic beats or arrhythmias, these abnormal rhythms will distort the R intervals and it'll violate the assumptions of the analysis. Last but not least is respiration. So with measures of heart rate variability, you should really have concurrent measures of respiratory frequency. And as I noted earlier, a respiratory belt would be sufficient. But if you can't record respiration, it's recommended that you control for breathing rates. You actually put your participants on a metronome and have them breathe 15 breaths per minute. So this is that push button approach that I told you about that's available with LabChart. And I have a video up here on top as to how to actually use the video or how to actually use the macro. But I'm going to focus on the data that you're going to get once you're done. And I'm going to focus on the time domain results and the frequency domain results. So what is time domain? So heart rate variability assessed in the time domain, you're really just looking at the intervals between those normal QRS complexes. So the milliseconds that I showed you in the earlier figure. And then you can do some statistical operations to measure the dispersion. So if you want to know just overall variability, so like in the initial slide, I said heart rate variability is a nice non-invasive way to look at the modulatory influences of the sympathetic and the parasympathetic branches. You can go down here and use this SDRR. So that's a standard deviation of the sinus beats, so just normal R to R intervals. And that gives you a nice measure of overall heart rate variability. But if you're specifically interested in cardiac vagal modulation or parasympathetic modulation, there's two others you could focus on, which would be here the RMSSD, which is just the root mean squared, or this PRR50. Now, you get a lot of other data from the program as well, but these are the key ones that you'll see in most of the papers that you read. And so I highly recommend that you would use some of these. Now, in the frequency domain, it's a little bit different, but the heart rate signal is broken into its constituents or its frequencies, and that's then quantified relative to intensity or power. And you can change these different frequency bands. So on the left here, you see the results of the frequency domain, and you see the low frequency band is 0.4 to 0.15 hertz. The program allows you to change that. But in general, if you're looking at sympathetic or parasympathetic, balance, so the imaging down here on the bottom, you might want to look at the low frequency band of heart rate variability, so the 0.4 to 0.15. And these data should correlate pretty well with the SVRR that I went over on the previous slide. However, there's a lot of controversies to the validity of the low frequency measures reflecting very specifically cardiac sympathetic modulation. So you may see some papers that say, cardiac sympathetic activity has gone up with our intervention because we see a change in the low frequency band. And I think you should be really careful making those types of assumptions. However, on the other hand, this HF, or the high frequency band, is a nice measure of vagal modulation. So if you're going to use heart rate variability, I think you should really look at it as a way of looking at cardiac vagal modulation of heart rate. And I say specifically modulation, right? This is a very beat to beat. These are beat to beat changes. You're looking at modulation, not necessarily vagal tone. The other nice thing is that this high frequency should correlate with the RMSD and the PRR50 from the previous slide. And so I've had a mentor that told me, if you analyze the data 4 different ways and you get the same answer 4 times, then you're on the right track. So I think if you do both, it's going to be really important that the data agree with each other. All right, so that's it for heart rate variability. And so for the rest of the presentation, I'm really going to be focusing more on the sympathetic branch of the autonomic nervous system. And right now we're still just looking at activity, which means your participants are just quietly resting in the lab while you're looking at basal autonomic function. And so there's a few areas we're going to focus on. And the first one is plasma levels. So plasma norepinephrine. So norepinephrine is the primary neurotransmitter released from the postganglionic sympathetic neurons. So plasma norepinephrine is an accurate estimate of sympathetic nervous system activation. So we use this regularly in the lab, but you have to have the capabilities of blood sampling and then blood processing, so centrifugation, pipetting. So in some places this won't be as easy as others. The other thing is it's somewhat expensive. I want to say for us it's about $40 US to run a plasma norepinephrine sample. The other thing is it's very responsive to lifestyle factors. So you need to standardize a lot of things we've already talked about, but smoking, posture, whether your participants are supine or seated, whether your room is warm or cold, right? All these things we mentioned before that are really important to control. The other thing is we usually do our plasma samples first. And the thing is you don't know what your participants did for the hour before they came into the lab. Hopefully they weren't eating or exercising or anything like that. But just the movement and stress of getting to the research laboratory could alter plasma norepinephrine. So what we do is we have our participants come in, they arrive to the lab, and then we have them lie supine in the research space for about 20 minutes, 20 to 30 minutes before we take this plasma sample. So it's really important to take into consideration because we have in the past, pushed that a little bit and done it earlier, and then we'll see elevated catecholamines, which could just be due to the stress of being late for the research lab and running down the hallway or getting lost and things like that. So you really need to take the time to allow your participant to rest before you do these measures. The other thing to consider is that we, again, measure this in the antecubital vein in the arm. And approximately 50% of the plasma norepinephrine you're going to measure at that point is going to be coming from the sympathetic nerves in the arm. If that's not your research question, then that's not the place you want to take your sample. The other thing is whole body plasma norepinephrine responds really slowly to physiological maneuvers. That's one reason why you're going to want to have your participants rest a while before you do your measures. It's the other reason why it might not work well if you want to know, for example, the sympathetic response to an apnea. Apneas could take, so someone holding their breath, they might hold their breath for 20, 30 seconds. If you expect to see an immediate change in measurable change in plasma norepinephrine, with that apnea, it may not happen because this is going to be a very slow response. It also can be misleading because if you think about it, the norepinephrine has to be released from the nerve terminals, then some of it's going to be taken back up, some will leak into the plasma, some of it's going to be cleared and metabolized, and so you're not getting a direct measure of the norepinephrine that's released from the nerve terminals. It's going to be a result of a variety of factors. That being said, the gold standard would then be microneurography, which is actually a direct recording of discharge rates of the postganglionic sympathetic neurons. And this is something you can do in humans. So the premise of it is really you position the tip of a microelectrode into a peripheral nerve. Here we're testing the fibular nerve. And you can actually do direct and continuous measure of sympathetic nervous system activity. And you saw this in a couple of the previous slides. Sometimes this is reported as bursts per minute. And so if you look at this figure here, we're really measuring activity of sympathetic action potentials recorded from this tip surrounding the tip of the microelectrode. And you can see that you have these fluctuations in voltage, and we call these fluctuations bursts. And so quite often we'll count these bursts over a number of cardiac cycles or over time, and we'll get a measure of sympathetic activity. However, this approach requires a lot of training and time and patience in order to be able to get consistent and interpretable recordings. You really need an experienced mentor to train you on this approach. It's also an invasive procedure, and it can't be repeated often. So once you do a recording in a given leg, you're going to want to wait at least 4 weeks before you do that recording again. And depending on your research question, your intervention, this might not be reasonable. It's also quite difficult to maintain recordings. So if you want to measure a sympathetic activity, not just at rest, like we're talking about now, but also in response to a stressor, it is actually very difficult to maintain this recording. Participants need to remain relaxed, and any sort of movement could dislodge the electrode. So that being said, I could give an entire hour presentation on microneurography, but thankfully someone else has already done that for me. So I have a list of videos, not only about the recordings from Vaughan Macefield and how to use the software, but then experts from ADInstruments on how to, again, do this analysis in LabChart. And if you're still have an interest in learning more, ADInstruments actually offers these microneurography workshops. And so I have just a screen capture of their website if you want to look into that and just record your interest in participating in one of these workshops. All right, so we're ready to measure basal activity of the autonomic nervous system. So this is my lab. So my lab's in the MU Physical Activity and Wellness Center at the University of Missouri. This is our space here. This is our command center, and I'm going to take you up here for a second. So what equipment do you need, or primary components, to measure activity of the autonomic nervous system in human research participants? We have a power lab, and we have a 16-channel because there's tons of stuff we're measuring: heart rate, blood pressure, breathing, oxygen levels, sympathetic activity. So we have a power lab. Then we have the ECG biolamp so that we can measure heart rate, or ECG. Then I have the older non-invasive blood pressure system, but here we have the human NIB blood pressure unit, so we can get beat-to-beat blood pressures. And then this is the NeuroAmp X. So this is where we do our microneurography or measure our muscle sympathetic nerve activity. And then in here, we also plug in our respiratory belt transducer. So this is where I was recommending that you should consider using a respiratory belt just so you can monitor breathing, because it's going to be really important for heart rate variability as well as sympathetic activity and your other cardiovascular components. So here's our research participant now, instrumented with all those pieces of equipment. Again, he's got our ECG to measure heart rate. He's got the blood pressure cuff, so it's a little beat-to-beat cuff that you put on the finger. Here it's on his index finger. We calibrate that to an upper arm blood pressure cuff that you can see over here. Then he's got all set up for microneurography in the peroneal nerve, and then he's wearing the respiratory belt. So if we're going to measure activity, just basal activity, we're going to have our participants quietly resting, and they're going to be awake. We're going to have them lie here for about 20-30 minutes and you can see he's got an IV in, so we get a measure for plasma catecholamines. Then we're going to do a 10 to 15 minute resting recording where we're getting beat-to-beat ECG, blood pressure here in the blue. We're going to have monitoring his breathing. We'll put him on a metronome. And I just have some of the sampling and filter rates here as well that we use. And then we're going to be measuring sympathetic activity using microneurography. And then we'll also run these files through the NICO extension so we can get estimates of stroke volume, cardiac output, and total peripheral resistance, as well as a heart rate variability module so we can get time and frequency domain analyses. So now you are ready to measure basal autonomic function in your human participants. So if you want to move on then to sensitivity, and I wish I had more time to go over all of these, but I don't. But again, this is the capacity of the organism or sense organ to respond to a stimulation. So I'm going to focus primarily on the baroreflex sensitivity, which we talked about earlier. So if blood pressures are controlled variable, our baroreceptor is going to sense this change in blood pressure and elicit a reflex response. There's a number of different ways you can measure baroreflex sensitivity, but because I want to focus primarily on non-invasive approaches, I'm just going to talk about the spontaneous measures. So again, the premise of baroreflex sensitivity is that you're going to be looking at these continuous changes in blood pressure, and these changes are going to elicit reflex changes in vagal and sympathetic outflow, very similar to that initial figure that I showed you in the presentation. And so we know that an increase in blood pressure is going to either reduce the firing of sympathetic, vascular, and cardiac efferents, as well as increase firing of the vagal cardiac efferents. So if you want to measure sympathetic, vascular, and cardiac efferents or vagal cardiac efferents, you're going to need beat-to-beat heart rate, blood pressure, and sympathetic activity or MSNA monitoring. And then to define the baroreflex, you're going to consider both. So your changes in your heart rate and your changes in your sympathetic activity. And the spontaneous approach specifically, you're just going to record during spontaneous breathing and just resting blood pressures for about 10 minutes. And you're either going to monitor breathing or control breathing. So your data are going to look something like this. So this is adapted from a paper from John Halliwell and Chris Minson. And if you're interested in specifically how they do the analysis, is a really nice paper in JAP from John Halliwell in 2000. But again, the premise for baroreflex sensitivity, if we focus first on the left, so cardiac vagal activity, you're going to look like changes in heart rate in response to changes in systolic blood pressure. And so as systolic blood pressure falls, the heart rate will increase. On the other hand, if you're looking at the sympathetic component, you're going to look at changes in muscle sympathetic nerve activity, so done with microneurography, in responses to changes in diastolic blood pressure. And again, as diastolic blood pressure falls, for example, you'll see an increase in sympathetic activity. So there's also, if you're interested in baroreflex sensitivity and doing this analysis, there's also a really nice video from ADInstruments on doing an automated analysis of baroreflex sensitivity, and the link is up here. So I just want to point out, this was a really nice figure that was shared with me from Laura Viana. And so what I just want you to see is I'm talking about spontaneous baroreflex sensitivity, which just means you're just measuring heart rate, blood pressure, and sympathetic activity, just these spontaneous changes at rest. And then you'll get a slope of the relationship between, in this figure outlined in the blue, sympathetic activity and diastolic blood pressure. So in these open circles is that baroreflex gain, or the slope of the relationship between diastolic blood pressure and sympathetic activity during spontaneous changes in blood pressure. So what I just described. And what you'll see is that in some individuals with low sympathetic activity, you're really not going to see much for a slope. And if you then do something that gives you greater fluctuations in blood pressure, like a modified Oxford, which I have on one of the original slides about baroreflex sensitivity, you're going to get a very different slope. And so the modified Oxford is just what we're seeing here in figure B, where you give a bolus intravenous infusion of nitroprusside, you have a swing in diastolic blood pressure and systolic blood pressure, so a reduction, and then you give a bolus infusion of phenylephrine. So a more invasive approach, but what you can see, or I hope you can appreciate, in those individuals with low sympathetic activity, there's potentially not going to be much of a relationship between a spontaneous measure and a measure using greater fluctuations in blood pressure like the modified Oxford. The other thing I want to point out with baroreflex sensitivity are two things: that the cardiac baroreflex sensitivity is not correlated to the sympathetic baroreflex sensitivity. So that's something to take into consideration. If your lab is only measuring cardiac baroreflex sensitivity, those data most likely will not correlate to the sympathetic, as well as the potential for hysteresis in the baroreflex. And this is a really cool concept that I think is not looked at that often, but the idea that the relationship between blood pressure and sympathetic activity is different whether your blood pressure is rising or falling. So if you're interested in baroreflex sensitivity, two other things that you could consider when you're doing this analysis. All right, I said I was going to do activity, sensitivity, so this is the last part, reactivity. So if you want to look at how the autonomic response or the autonomic response as a result of stress, there's a couple of common procedures that you could use. And I have just a few here that I'm going to go through. But conceptually, the study design is about the same for any of these tests, in that you're going to start with a quiet resting period. Now, if you've already measured basal autonomic function, this resting period could be shorter, so 2 to 5 minutes. You're going to expose your participants to a stressor, so perhaps one of these here in the list. And the time of the stressor could be different depending on what sort of stress you're doing. So if you're doing hand grip versus ischemia, mental stress, or a cold pressor task, the timing of the stress may differ. But a really important thing is that once you've completed the stress, you need to have a washout period. And this goes back to the idea of taking plasma norepinephrine samples as your participant arrives to the lab. You really need to make sure that the response to the stress has been washed out and your participants are back to baseline. Depending on the severity of the stress, this washout period could be quite long, and you just need to be prepared for it, because the last thing you want to do is do another test and you're actually just looking at the compounding effect of doing 2 stressors in a row. And then your outcome measures, again, if you're a cardiovascular physiologist like me, you're going to be looking at your heart rate, your blood pressure, and your muscle sympathetic nerve activity. So first I'm going to start just with isometric hand grip exercise and post-exercise ischemia. And so you may choose this if you're very interested in specific mechanisms like what you would see with hand grip exercise. So when you conduct a hand grip exercise, you're going to have central command or the thought of doing the exercise, as well as mechanoreceptor activation and metaboreceptor activation. So I'm just going to refer you down to this figure here. So the mechanoreflex, these are mechanically sensitive receptors. So that's just the mechanical stimulus of doing the exercise, like squeezing your muscle to do the hand grip exercise. Where the metaboreceptors are going to be these metabolically sensitive receptors. And so these are going to be the metabolites that are released during the exercise that are going to be activating their own receptors. So that means when you do this post-exercise ischemia, you're going to actually be able to isolate the effects of the metaboreceptors. So what that means is you're going to do the exercise, you're going to have this mechanical stimulation, you're going to release these metabolites. Before the exercise is over, you're going to inflate a cuff on the upper portion of the arm to trap those metabolites so you can maintain receptor activation. You'll have the participant stop exercising, and now you're only looking at the metaboreflex. So really nice. And your outcome variables, as you can see in the figure, you're going to see an increase in sympathetic efferent activity, which is going to increase your blood pressure, increase the heart rate, and increase left ventricular contractility. So the premise of this is really the body wants to find and then restore muscle blood flow and the intramuscular concentration of the metabolites to some sort of optimal level. And it's going to achieve that by raising blood pressure and cardiac output. So if you're going to choose to do isometric hand grip exercise or post-exercise ischemia, you're likely going to use this approach because you're interested in the mechanoreflex or the metaboreflex. Your protocol will look like this for your participants' rest. They conduct the exercise, then you're going to inflate that cuff to supersystolic pressure. They'll stop the exercise and you'll maintain the ischemia for a certain amount of time. So in my lab, it looks something like this. So our participant is using the grip transducer, which we got from ADInstruments. We're feeding that actually into a second power lab because we want him to be able to see his workload. So we put that laptop up there so he can actually see what workload he's doing. Then we have this cuff inflation system so we can rapidly inflate the cuff to conduct the post-exercise ischemia. So a lot of words on this slide because I think it's really important to consider. First, you want your exercise, you want to reach it quickly, the target quickly without overshooting. And I think the best way to do that is to have them actually be able to see it on the screen. So then they want them to maintain constant force. So again, it's really helpful if you can give them visual feedback. But as you're designing these studies, you're going to want to think about what workload, how long, and then you're going to want to ask at the end the rating of perceived exertion because you're going to want to see whether all the participants perceive the stress equally stressful, for example. During the ischemia, again, your pressure is going to want to be supersystolic and you're going to want that rapid inflation. You don't want to inflate the cuff slowly. I'm just going to refer you to a fantastic paper that was just published by Gabby Dillon and colleagues in JP looking at the reproducibility of these tests. And I have the information here, but for sake of time, I'll just encourage you to take a look at that paper. So the way our data look, there's something I want to just point out in that in LabChart, you can actually pull this left side of the screen over, and then I do a 10K to 1 compression so that I can see the time course of our changes. And so you can see your resting data, then your exercise response, and the response to ischemia in real time, which is really nice if you want to monitor trends, or like you can see here during the MSNA, we actually have a shift in our MSNA signal here in the green. The other thing I like to do, and you can see this little red box now over by ECG. It says no sampling because this is just an image capture of some of our data. But what I actually do is click here and drag over. And something you might have noticed is we use 2 monitors in the lab, and I like that because I'm going to flip here and focus on that second screen. We use that second screen as a patient monitor, so we can actually monitor beat-to-beat changes in heart rate and blood pressure from across the room, so we can make sure our participants are staying in those safety levels that we may have told our IRB. So for example, we may not want a rise in blood pressure greater than 20 or 30 millimeters of mercury during a given test. And it's really easy for us to monitor that if we use the second monitoring screen. All right, 2 more. So mental stress. So for mental stress, the premise is that you're going to want to use an acute laboratory-based psychological stress. The nice thing about it is there's minimal physical movement. So with isometric hand grip, your participants can get fatigued and start to shake, and you can have the potential to lose that electrode position if you're doing microneurography. Where with mental stress or psychological stress, there's less movement. But again, it depends on your question and it depends on the mechanism you're trying to assess. You also want to consider when you're doing mental stress that extreme stress has ethical implications. So you want to think about the stresses that you're choosing to use and the population you're using them in. Again, I refer you to now some work from Jason Carter and Ida Funkui and the reproducibility of this. However, it's something really interesting is that you will have MSNA responders and non-responders to mental stress. And I'm going to show you that in the next slide. But some options for mental stress are the mental arithmetic test, and that's actually associated with greater anxiety levels and blood pressure elevations. Or in this image here, one I really enjoy doing actually is the Stroop color word conflict test. But either way, you're going to want to ask your participants the psychological distress survey at the end, just so you can gauge the level of stress each of the participants felt. So I refer you, this is a fantastic paper from Chloe Taylor's group that I think takes a lot of these ideas all together. And so it has to do with what they were seeing as these MSNA responders and these non-responders to mental stress. So the mental stress is just this black bar here down at the bottom, and that's when the participant is going through mental stress. And you can see on the left, one participant has a rise in number of these bursts of sympathetic activity, where the other participant doesn't. And so this is very reproducible. And they think it comes back to the Baroreflex. So my point with this, and I encourage you to read the paper, is that you may be looking at mental arithmetic and thinking you're just looking at reactivity. But you also need to take into account this activity and sensitivity as well as you're doing these recordings. And last, a test we use a lot in the lab, the cold pressor test. So the cold pressor test assesses the reactivity to just a generalized sympathoexcitatory stimulus. So it actually activates these sensory afferent nerve fibers or these cold nociceptors. Point being, again, if you want to do a reactivity test, you need to really think about what your research question is and the mechanisms you're trying to attack, and that will help you decide which test you want to use. Again, refer you to the paper from Gabby Dillon on the reproducibility, which is very good within and between experimental visits. And the procedure is quite simple. The participants immerse their hand or foot into a bucket of ice, monitoring the temperature of the ice, and then monitoring their ratings of pain and thermal perception after the exposure. And during this testing, your participants really need to avoid isometric contraction. So when you go in the ice water, you have a tendency to clench your fists, tighten your abs, hold your breath, squeeze your butt. And you just want to ask your participants to avoid all of this. And one of the best ways to monitor this is a respiratory belt. And it's going to look something like this. So here's our research participant with his foot in a nice ice slurry here. All right, so I went through that pretty quickly, but if you have any questions, you can always refer back to the recording. And we should have about 10 minutes here so I can answer any questions you might have. But hopefully you got an idea of the equipment that you might need if you wanted to do human autonomic testing. Certain things you need to consider in your research space, whether it's temperature or activity in the rooms outside of your research lab during testing, which tests you want to do, whether you just want to look at basal or possibly reflex autonomic control, the pros and cons of some of these tests and approaches, so that when you do this in your lab, again, hopefully you can anticipate and avoid some areas that could increase data variability or make it really difficult to interpret your findings.
Excellent. Thanks so much, Jackie, for the really brilliant presentation. Moving right on to the Q&A. Looking for a question here. So this one comes from Sarah, who's asked, if you could please specify some of the effects of the menstrual cycle on autonomic activity and whether you have any recommendations for controlling for this.
Oh, that's a fantastic question, Sarah. An area I'm actually really interested in. So in my lab, if we're only going to do a single study visit, quite often we will study women during the early follicular phase of the menstrual cycle, so typically somewhere between days 0 and 7 following menstrual bleeding. And that's just because in that phase in the menstrual cycle, estradiol is lowest in the women. And so characteristically, people will say that women look most like men, quote unquote. But I really recommend that you take a look in Journal of Applied Physiology. There was recently a point-counterpoint about controlling for menstrual cycle phase in specifically human cardiovascular studies. And a lot of the authors do autonomic testing. And there's a lot of fantastic opinions. And I think the easy answer is it depends. Second is it's definitely affected. So depending on the phase of the menstrual cycle, you study a woman and you will see differences in muscle sympathetic nerve activity, sensitivity, and reactivity, although it depends on the study that you look at. But I do believe there were 26 letters to the editor following that point-counterpoint from just tons of experts in the field. So rather than me answering that, I think I would refer to that fantastic resource to hopefully help tailor that answer to the types of questions you may have.
Excellent. Great answer. Thanks so much, Jackie. We've received a number of questions here on controlling breath rate using a metronome. So does this cause stress for the individual? And do you always recommend controlling breath rate during HRV assessment?
Yeah, I think that's such a good point because I do think it causes stress. In the situations where we've used a metronome, because it is important to control respiratory rate for some testings. For example, you really don't want people to be apneic during certain tests, but it does increase stress. It's actually hard to breathe with a metronome. It's just very unnatural. So do I recommend it? I recommend that you measure it first. So if you're going to do heart rate variability assessments, the best thing you could do is just measure respiratory rate because that will help you make sure that they're not apneic, they're not holding their breath, they're not falling asleep. And some people would recommend that you would do just a normal recording, so a 5-minute recording not on a metronome. Then repeat and do another 5-minute recording on a metronome, and then report both of those. And I would say, in general, we do not use a metronome in the lab. We just record respirations and then report them. And I would say, as long as the participant's resting quietly, the respiratory rate's pretty regular. And you can just report that on average during our heart rate variability measures, our respiratory rate was around 12 breaths per minute or something like that. But yeah, everybody makes a really good point, whoever wrote those in, that the metronome causes a lot of stress.
Excellent. Thanks so much, Jackie. Next question here from Mahmood, who's asked, can we measure HRV from blood pressure waveform rather than ECG?
Oh, that's a good question. I will say when our ECG is fuzzy or there's something wrong with ECG and we're not sure about the recording, we will use the non-invasive blood pressure for a measure of heart rate. So if we just need to say, during rest, heart rate was 60 beats per minute, you could probably use the non-invasive blood pressure. However, that peak of the blood pressure is kind of rounded if you've ever zoomed in on it. And you're not going to get the resolution, that 1 to 2 millisecond resolution in that signal that you really need for an accurate measure of heart rate variability. So I wouldn't recommend it. I would recommend using an ECG signal where you have a high sampling rate of about 1,000 hertz to really make sure that you have the resolution. Because I don't think that, what I'm saying, there's it's just a little weight curvy on the top of the non-invasive blood pressure. And it's not going to give you that tight resolution that you need.
Excellent. Perfect. So here's a question here. What's the difference between NICO TPR software, so non-invasive cardiac output total peripheral resistance software, from TPR measured from finger blood pressure?
It's essentially the same. So ADInstruments, I don't know how many years ago it was, essentially got access to the same algorithm. So if you use a FiniPress, and the FiniPress, independent standing, an independent device that's not associated with ADInstruments, it will give you an estimate of cardiac output, stroke volume, total peripheral resistance. And essentially, ADInstruments, you took that algorithm and created this NICO software. So it's very similar in that it will look at the pressure waveform of the finger cuff, which is what the other systems use, to get an estimate of stroke volume. And from there, you calculate with heart rate, you calculate the cardiac output and the total peripheral resistance. So the technology is very similar. It's just built into the software.
Perfect. Question here, is there a gold standard method for measuring sympathetic activity during a VO2 max test on a cycle ergometer or a treadmill? And they said, I assume it's not microneurography?
Not in my lab, but there are people who can do it. I trained with microneurography. I primarily do it in the peroneal nerve, which is in the lower limb. But there are groups that do it in the upper limb. So you can have individuals cycle while you have their arms resting kind of on a board. And you can do microneurography in the upper arm. So it is possible. I've never done it, but there are people who can. I'm not sure if you can get all the way to max because it's just so much body movement, but it's definitely possible. So I think there are people out there, if you go on PubMed, I think you could take a look. There are people who do microneurography during cycling.
Excellent. And I think in the interest of time, I think we're just going to have a few more questions. Might go a bit over time, but we'd like to get 10 solid minutes of questions in here. So the next one is one from Jack, who says, afferent-efferent signals from heart and viscera to vagus via nucleus tractus solidaris is greater than vagal efferents. And can you comment on this?
Oh, can you repeat that?
So it's afferent signals from heart and viscera to vagus via nucleus tractus solidaris is greater than vagal efferents.
Yeah, I guess the easiest answer is that when we're doing research in humans, we can only measure what we can measure, I guess. So there's always going to be known limitations to the recordings that we do. And I would agree that when you're measuring heart rate variability, it's obviously heart rate is modulated by, more than just cardiac vagal activity. And so you're going to have all these extrinsic inputs as well. And I guess the importance is to know what you can record and then understand the limitations of it. I'm not sure if that completely answers the question, but I agree that we're very limited in sometimes what we can do in humans. And that's why I think it's nice if you can do some translational work with some collaborators and just understand the limitations of your methods.
Perfect. Thanks so much, Jackie. And I think in the interest of time, we'll just make this next question the last one, which is coming in from Sarah, who's asked whether you have had any success with wearable devices.
Oh, for example, for heart rate variability, I know a lot of people use them. I think the importance is if you're going to use it and you're going to trust the data from it, you should know your sampling rate, because depending on the piece of equipment you're using, if your sampling rate is under 200 hertz, you should be concerned as to the reliability of your data. Same thing if your signal's filtered or if you're just getting like a black box set of numbers from it. The other thing you could do then is just to take a look, for example, at the time domain and the frequency domain data. Like I said, they really should align. And if you're getting 10 data points and you only use 2 of them because those are the numbers you like, I think there's a significant limitation in that. But I personally haven't used wearable devices, but I think if you do, you really just need to know what your sampling rates are and filters and things like that.
Fantastic. Great answer. All right. Thanks so much, Jackie, for all your really excellent insights during your presentation as well as the Q&A session here.
Oh, thank you. This is so much fun.
Agreed. And a big thanks to everyone for joining us today for our webinar. And last but certainly not least, a big thank you to ADInstruments for sponsoring this event. So in closing, thanks again for taking part in this American Physiological Society webinar, and we look forward to having you with us again soon.